Good day, my name is Victoria, and I will be your conference operator today. At this time, I would like to welcome everyone to the Myeloma 101 Updates on Treatments and Pain conference call. All lines have been placed on mute to prevent any background noise. After the speaker's remarks, there will be a question and answer session. If you would like to ask a question during this time, simply press star, then the number 1 on your telephone keypad. If you would like to withdraw your question, press the pound key. Thank you. I would now like to turn the call over to Susie Novus. Ma'am, you may begin.
Thank you. Well, good evening, everyone, and welcome to the IMF final teleconference of the year. And I have to say, this is a very informative one. Our speaker tonight is Dr. Brian Durie, and he'll be covering two very important topics, Myeloma 101 updates and pain management perspectives. He'll also give you a preview of what to expect from the upcoming annual meeting of ASH, which is the American Society of Hematology. ASH is our premier meeting of the year, and getting a preview of what the most important updates will be presented at ASH is really great. He'll also be discussing a very important topic, pain management. I'm sure many of you on the call tonight will agree that this is very important. Dealing with pain really impacts our quality of life, and I know Dr. Durie will have some very good advice on this. Before I turn it over to Dr. Durie, I'd like to take a moment to thank our sponsors of tonight's teleconference, Bristol Myers Squibb, Celgene, and Takeda Oncology. It's really wonderful that they support this program, and it's greatly appreciated. One last thing, as a reminder, you'll find a link to tonight's slides by going to our website and under New and Noteworthy, which is on the right-hand side of the page, and it's the first bullet down. That's the link to the slides. Just click on it and you'll be all set. So now sit back, relax, and Dr. Durie, it's all yours.
Well, thank you so much, Susie, for that kind introduction. This talk is coming to you tonight from sunny California. On my first slide, you have Santa Monica Beach. Currently, it's in the mid to upper 70s here, a beautiful day. So we're very pleased and fortunate to have beautiful weather out here. If you go to slide number 2, I've got a summary of what I want to cover in tonight's discussion. I decided that for my 101, the most informative thing to do is to update you related to the upcoming ASH presentations. As Susie said, this is our premier meeting of the year, and this year we had close to 800 abstracts submitted for consideration. And it was a very tough job for myself and Debbie Burns, who is our medical editor. We spent a lot of time going through these abstracts, coming up with what we think are the key abstracts that are informative, both to cover research and what I've called clinical pearls. And these are very important clinical points that can guide decision-making for patients. And I thought it would be very important to focus on those. And then the prescribed special topic, which was some details about pain management in myeloma. And so if we go to slide number 3, I am going to start with my summary, a preview of ASH. And so this is going to be a bird's eye view of ASH. Early in the new year, I will be giving updates once we have a chance to hear all of the different presentations. However, I thought it would be incredibly interesting for you to see what we have in store for us this year at ASH. A very, very busy time. So I've broken the abstracts down into what I call the top 10 topics. And it's most interesting that this year, without a doubt, minimal residual disease is the top topic for discussion, and I'm going to go into that a little bit. Minimal residual disease, MRD. There is also a big focus on molecular testing and the idea that myeloma, as it evolves through treatment, breaks down into different subclones, which may require different treatment options to get rid of any resistant subclones. There is an emphasis this year on the use of 3-drug therapy as a first approach to treatment and the role of transplant along with this. And so this has been a big open question, as many of you may know. And the role of transplant itself is now a more important discussion versus what it has been in the last 2 or 3 years, where we've mostly focused on just the role of the novel agent combinations. I then go into the details of several of the new drugs, Carfilzomib, Xeloda, anti-CD38, and I'll discuss the very exciting news, which the one monoclonal antibody, daratumumab, was just approved by the FDA on Monday, for those of you who may not have caught this news. So this is very exciting news, which I'll discuss a little bit. And then elotuzumab, the checkpoint inhibitors, and then a summary of these clinical pearls that I mentioned. These are clinical tips from studies that really can impact day-to-day decision-making. And so if we go to slide number 4, this is my overview of the minimal residual disease abstracts. And so as you can see here, over 20 abstracts on this topic, clearly very important. The format that I've used is that on the bottom right of these various slides, you'll see that I've listed the abstract numbers and I've indicated whether they are oral or posters. And one thing that you can see here, that there were quite a number of both oral presentations and posters listed for minimal residual disease. As you go through, you will see that this is the most for any topic that I touch on today. So this is really quite remarkable. And one thing that I didn't emphasize on slide number 3 that is that in addition to the regular abstracts, orals and posters, there are some special sessions this year where there is a special session called Path to a Cure, where Dr. Alberto Orfeo from Spain will be leading off with the assessment of minimal residual disease. He's one of our major collaborators, and he is going to be highlighting MRD testing as part of the search for a cure. The abstracts on MRD, minimal residual disease, focus on the different tests that we have, the idea that different subclones can emerge during the treatment of the disease, the possibility of using blood tests versus bone marrow tests, which would be a huge benefit and relief for patients, and the role of various other new methods to assess MRD, and of course, clinical trials linked to this testing. And so if we go to slide number 5, I thought it would be helpful just to give a little bit of a background so that you can be aware of what we're expecting to come out of ASH. So where are we with the different tests that we use for MRD testing? And this slide shows the testing comparison between the flow method and the sequencing method. The flow method is where you take the bone marrow and you pass the cells through a special flow cytometer, and in this case it uses an 8 antibody or an 8 color method, and it's a special method that has been developed as part of the Black Swan research initiative. And in this table here, you can see the results with the NGF, the new ultrasensitive flow method, but with the sequencing method, NGS, you can see on the left-hand side. Now, these data will be updated at ASH. We don't have those new numbers yet. They will be presented at ASH. But if you look under the plus table, you'll see that of the samples tested, 2 out of 14 at the very, very low sensitive level were positive with flow and were actually negative with the sequencing. And so this tells you that actually the flow in this comparison was more sensitive than the sequencing at the 10 to the -6 level. So the new flow method is what we would say equally sensitive versus the sequencing. And so what we need to do now is to compare both of those methods. One thing that I've listed at the bottom of this slide is that unfortunately the NGS, the sequencing is not possible in every case, and in this case only 88% of the patients were able to have samples that worked well for the sequencing. If we go to the next slide, the other thing about the sequencing is that we do have different methods. On the left, you can see that different companies like Sequenta, Immunosequence, and InfoScribe, and also independent lab methods can be used. And so one thing that we need to do is to look at standardization of the sequencing methodology. So one of the things that will be discussed at ASH. So if we go to slide number 8, what I show you here is what are the different ways to do the MRD monitoring. What I've been focusing on is the bone marrow, where you can look at how many cells are in the bone marrow, what we call cellular clonality, and we can assess by the NGS or NGF. But you can also look at what are the myeloma cells producing. Traditionally, we look at this using the myeloma protein level. You can also look at it using the free light level, the heavy light level, which is a new quantitative method which looks like it will be quite useful as a blood test, and also some new evolving methods to measure in a very sensitive way the M-spike levels. But in addition, if the bone marrow is not showing disease, there could be disease outside of the bone marrow, and this would have to be picked up with a PetCT scan or an MRI or some other kind of a scan. And so we need to look at these in a complementary way. If you go to the next slide, what I show you here is where are we in terms of sensitivity that would guide us towards possibly achieving a cure for myeloma? Are we there yet? So if we have a patient that is negative, so the bone marrow test shows negative at 10 to the minus 6, that means that if we have a test that would pick up 1 out of 1 million myeloma cells, and is that test negative, then does that mean that if that is sustained, a patient might be cured? Well, we don't really know yet, but we do know if it's at 10 to the minus 4, patients probably will relapse over a 1, 3, 5 year time span. 10 to the minus 5, we're not sure. So if we go to the next slide, slide number 10, you can see that there is then a listing of different categories of MRD negative. And so if you're MRD negative and you go along and you don't relapse at 10 to the minus 6 after 1 or 3 or 5 years off of treatment, this really could be moving towards what we call a functional cure or a potential cure. But if you relapse on therapy or subsequently off therapy, then this is something that we need to study in another fashion. And there are a number of abstracts looking at this kind of relapse, where one studies MRD positive patients. So you have MRD negative, where we are hoping that patients will not relapse. And then we have MRD positive patients where there may be relapse, and we need to see what type of relapse. This can be a persistent, what we call an MGUS signature, where the disease is not really active, but we are seeing cells that have a pattern just like MGUS, which is steady and does not need treatment. Or we may see resistant myeloma, and this needs further study and potential new treatment. If you go to slide number 11, you can see a model of how this looks. So if you're MRD negative, we have a decision now in blue that you could perhaps maintain on a maintenance for a year or maybe more, or decide at some point to stop the treatment. We need more evaluation of that. If there's an MRD positive, then we have the ability to study those clones or different subgroups of disease and develop better therapy for that. And so these are what we call phase 2 of our Black Swan project, which is in evidence in the abstracts being presented at ASH this year, where there are studies looking at MRD negative cases, studies assessing, well, what are these clones which have persisted and are giving an MRD positive test result. So if we go to slide number 12, I'm moving through what are the different categories in this preview of ASH this year. A lot of abstracts on molecular testing, DNA sequencing, RNA sequencing, mutational analyses. Clonal evolution is a big theme this year. People are really starting to study and focus on the idea that you give treatment, get rid of most of the myeloma, but there are some subclones left, and that's what we need to study more. Are there what are called driver mutations that make those cells resistant and can lead to new clones over time? And this is the point of discussion in a number of these oral and poster presentations. But if you look at the bottom right, you'll see that there are a number, but not quite as many as we saw in the MRD category. If we go to number 3, this is a big focus at ASH, and really there's a big emphasis this year on how much can be achieved with using 3 drugs as a combination versus 2 drugs, for example. And this is illustrated in the SWOG study, which I will show you a little bit about. But then there are abstracts looking at different triplets, different 3-drug combinations. We can have Velcade, Revlimid, and Dex versus RD, Revlimid, and Dex, or Velcade, Revlimid, and Dex with or without an autologous stem cell transplant, or Velcade, thalidomide Dex versus Velcade, Cytoxan Dex, or Velcade, melphalan, prednisone, Velcade Dex versus Carfilzomib Dex. So a number of trials looking at those, and it is going to be very interesting and important to see the details of those. Now, I am going to show you a little bit about the SWOG study. I happen to be the principal investigator of this, and so this is just to give you an idea of the sort of presentations that we're going to be seeing a lot of at ASH. And so if you look at slide number 14, SWOG S0777 study design, and in blue you'll see that half the patients get 6 months of Velcade, Revlimid, and Dex. The other half of the patients get 6 months of Revlimid and Dex. So there's no upfront transplant in this trial, and it's stratified by an intent to transplant later. And so if you go to slide number 15, you'll see that after the first 6 months, the patients then all receive ongoing Revlimid and Dex maintenance until there's progressive disease or they have side effects and the like. And so now, this was a study that was started 7-8 years ago. 2007 it was planned, which is where we get the 7s. If you go to slide number 16, now I'm able to show you these little bits of data on this slide and the next slide because these were actually part of my abstract submission, so these have already been published. For most of the ASH presentations, we don't have a lot of the final details. But if you look at slide number 16, you can see that using the VRD, the remission duration, what we call progression-free survival, is 43 months versus 30 months with the red curve, which is the RD. So 13 months longer remission if you start off with the 3 drugs versus the 2 drugs. If you go to slide number 17, you can see that this results in an average survival, a median survival of 75 months, which is over 6 years versus around 5 years. So about a 1-year difference in the overall survival. And so this emphasizes what we're seeing in a number of the other presentations at ASH, that 3-drug triplets up front are really important and do have a lasting impact. In this case, about a 1-year difference. And the curves are kind of flattening out a little bit at the 6-year mark. So really very encouraging to see these kinds of curves at this time point. If you go to slide number 18, there are a lot of additional abstracts on the role of transplant, and the most important one is the IFM Dana-Farber study, where transplant is given in a randomized fashion to patients who receive the VRD. So the VRD that you've just seen, these patients were randomized to get a transplant or not. And so we're very excited. We don't have the full results of the IFM Dana-Farber study, although we have a sense that the transplant is having a positive impact in prolonging remissions and survival on top of what would be considered to be maximum novel combination therapy with this triple therapy up front. But this emphasis on transplant is also reflected by the use of transplant for consolidation and salvage, and also an overview of allotransplant. So you can see several abstracts, oral and poster, on the topic of transplant, which is really reflecting a little bit increased emphasis on that this year at ASH. If you go to slide number 19, I'm going to move through what are the new bits of information about some of the newer drugs. So Carfilzomib has been approved this past year, and so we now have quite a bit of more follow-on type data, I would say. And so you can see we have now a comparison between Carfilzomib and Dex versus Velcade Dex. There's interest in the fact that we are expecting to have perhaps more and deeper responses with the Carfilzomib versus the Velcade, and so we're waiting eagerly to see results from this Endeavor trial. We also are waiting to see in detail about using the Carfilzomib, the CAR, what I call CAR is obviously short for Carfilzomib, once a week instead of the standard 2 times a week dosage, which is obviously quite inconvenient for patients. And so it's very encouraging to see preliminary data that certainly in triplets, for example, Carfilzomib, Cytoxan, Dex, that the once-a-week dosing is giving equally good results. So really quite encouraging data, which is very good news for patients, that 1 time a week dose could work well. Also, the possibility that by increasing the dose of the Carfilzomib, then some of the efficacy can be recouped and also get excellent results. We have additional data using different combinations with Cytoxan, with melphalan-prednisone, and some of the newer drugs, such as selinexor and the array compound. So very interesting abstracts there. If we move to slide number 20, Ixazomib. I don't know who picked that name, but anyway, it is an oral Velcade-like drug. It's an oral proteasome inhibitor, which is obviously tremendous. And we are very pleased to see the abstract presentation here. Dr. Demopoulos will present this. The trial, the pivotal trial, which has been submitted to the FDA actually for consideration, and we may get an indication of actually approval based on this very soon from the FDA. This is a trial in which Ixazomib by mouth is combined by Revlimid and Dex, and is compared with Revlimid and Dex alone. And so one advantage of this is that it is a totally oral regimen, and we know already that the 3-drug combination, again, is better than the 2-drug, as one might expect. And so this is quite important to see all the details of that, the side effects of that, etc. We also have a number of other follow-on Ixazomib trial results, combining with Cytoxan and Dex, another all-oral regimen. You can see a theme here, and then Ixazomib plus pomalidomide and Dex, another all-oral regimen, and also as a maintenance. So a lot of follow-through ideas about how best to use Ixazomib. So quite interesting information, also including the effects of dose escalation, which will be reviewed by Shaji Kumar, and also dose corrections or reductions if there are kidney or liver problems. If we go to slide 21, I thought it would be helpful as we review the other novel agents just to think about what are the targets for our additional novel therapies. And a lot of our novel therapies right now are immune therapies, particularly monoclonal antibodies. And so those are targeted against the antigens on the left of slide number 21, which are on the surface of the myeloma. And you can see that there are some antigens which are present on all myeloma cells, 100%. So these are CD56, CD138, CD319, and CD38, 100%. And those are ones in which there are treatments available. And so the daratumumab is against the CD38, and elotuzumab is against the CD319. And we have drugs against a number of the others. The PD-L1, that is the target for the checkpoint inhibitors. And so these are very, very helpful. And so in the flow analysis of the bone marrow plasma cells, the assessment of these antigens is quite helpful as a basis for selecting the optimal immune therapy that might work well. And likewise, on the right, you can see the various molecular mutations, which again can be the basis for a treatment selection. however, what are called actionable mutations. But really, there are only a few right now that are truly actionable, especially the BRAF, where we do have a treatment possibility with an anti-BRAF therapy. If you look at slide 22, it gives a little bit more detail about the immune therapies that we're going to hear about. We're going to get all the details on several of these monoclonal antibodies, the green dots with the corresponding antibodies, also the T cells, the NK cells, and the CAR T cells. There is a late-breaking ASH abstract which summarizes the results with the CAR T cells against the CD19, for example, and then the PD checkpoint inhibitor blocks the inhibition of the T cells, so that when you give the checkpoint inhibitor, what that means is that that T cell, the pink T cell at the top left, is actually able to attack the myeloma. Without that, the T cell is actually blocked. And so the inhibitor releases the block, and then the T cell can attack the myeloma. So, slide number 23. This is the anti-CD38 monoclonal antibodies. So, great news. Daratumumab was approved by the FDA in a very early decision, actually, for use in relapse refractory myeloma. And so the information, the release on Monday was great news, but really not a great surprise because daratumumab is active as a single agent in about 30% of patients with myeloma in the relapse refractory setting. So really very exciting new drug, a new monoclonal antibody to have available. And at ASH, it's sort of like an anticlimax, but we will be hearing the updates on the single agent and the combination results. We will also be hearing results of two other anti-CD38 monoclonal antibodies, the SAR compound and the MR202, which are obviously a little bit behind in terms of the drug development aspect. So if we go to the next slide, I just want to show you that we are very excited about the approval of the daratumumab because the daratumumab has been included in an upcoming cure trial in high-risk smoldering myeloma, which is part of the Black Swan project. And you can see on this flow diagram that the protocol in this cure trial for high-risk smoldering multiple myeloma, illustrated on slide 24, is KRD plus DARA, which is Carfilzomib, Kyprolis, Revlimid, and Dex plus daratumumab, with or without a transplant, with consolidation, and then some maintenance. And so we're very, very hopeful that this will be very successful and will, in fact, be starting to cure a significant fraction of patients with high-risk smoldering myeloma. So we're very pleased to see that the daratumumab is part of what we have picked for this particular very exciting pilot study. If we go to slide number 25, elotuzumab is the other monoclonal antibody that we're waiting to see how it is reviewed by the FDA. The FDA are currently reviewing the results of the ELOQUENT-2 trial, which is listed on this slide, and this is Revlimid and dexamethasone RD with or without elotuzumab. As you might imagine, and we've talked about this before, the RevDex plus the elotuzumab in patients who've had 1 to 3 prior therapies, the elotuzumab combination gives significantly longer remissions. And so we're waiting to see if that benefit is sufficient to impress the FDA and come forward with an approval. I would just draw attention to the fact that in this case, this is in patients who've had 1 to 3 prior therapies, not in the relapse refractory setting as was the case for daratumumab. So it's a little bit earlier, but still a very impressive result. We also have some data which will be presented in combination with Velcade and Dex, so another combination where there is an impact with elotuzumab. The checkpoint inhibitors, very early results. There is one. We've got another MAB for you to remember. In this case, I'm not sure if I can even pronounce it. On slide number 26, this is pembrolizumab, anti-PD-1. and this blocks that effect of the T cell so that now the T cell can attack the myeloma. There are two interesting oral presentations, numbers 505 and 506, one of the early presentations, priority presentations at ASH, with very encouraging results with these combinations. And so I think that this is going to be something we see a lot more of, combinations to have the effect of the T cells combined with the other effects from these other immune modulating drugs. And so finally, as far as ASH, what are the clinical pearls? Now, I don't have time to go through all of these clinical pearls, but I've given you the abstract numbers, and perhaps I'll just touch on a few to give you an idea of what I mean. And so if we start at the top of slide number 27, doxycycline. This is an antibiotic, and it's turned out that this can be part of an effective treatment for amyloidosis. So really quite remarkable, and so very helpful that this simple therapy, an antibiotic, can be helpful for the treatment of amyloid. Let me skip down to another thing which is very important for patients. Dex dose adjustment, okay. What do I mean by that? Well, there was a very nice study where the dexamethasone dose was reduced based upon the tolerability for the patient. And this worked out well as far as side effects, but it also worked out well for the patients in terms of benefit because the patients were able to stay on the dexamethasone for a lot longer and therefore benefit from the dexamethasone. And so appropriate dose adjustment of dex reduces the side effects and also has an excellent outcome. So a very, very important practical point. A very interesting point related to the risk of Velcade neuropathy. It turns out that that is linked very closely to the levels of calcium and hemoglobin at the start of treatment, which may increase the susceptibility of the nerves to the Velcade. So this is something that I'll talk about in more detail early in the new year. Another thing that is quite interesting is the use of RVD light in older patients so that older patients can receive the 3-drug triplet with dose modification. So that is a rapid bird's eye view of ASH and how many of these observations may impact very soon the day-to-day care of patients with myeloma. But I'd like to finish with my comments about pain in myeloma, and I have just 3 slides on this at the end, but just to emphasize the key points. Myeloma is a cancer where pain is a problem, especially because of the bone lesions. And so in slide 28, I indicate that this can occur when myeloma is active and growing within the bone. This obviously causes pain. If the bone would fracture, it causes pain. If there's pressure on a nerve or on the spinal cord, these are key ways in which you can have pain. Other sources of pain in myeloma are obviously from drugs which can affect the nerves. Velcade would be the classic example. Also a little bit, although not too much, with the new by-mouth Velcade type drug, Activism. Another thing which we should not forget about is that if there's pain, this could be because of a painful abscess, which could be in a tooth or in a sinus or your gallbladder. If there's a buildup of infection with an abscess, this can cause pain. So if you go to slide 29, how would you deal with that? Well, you would treat the myeloma, stop the drug, or treat the infection. These are the ways that you proactively deal with these things. And so this preventative or proactive approach is incredibly important for pain in patients with myeloma. And it cannot be emphasized too strongly that, for example, modifying the dose of Velcade, using Velcade sub-Q, adjusting the dose early to prevent the development of more severe pain is so incredibly important to reduce the amount of pain that ultimately can occur. Obviously, if there is residual pain, after myeloma treatment and drug treatment, etc. Surgery, radiation, vertebral or kyphoplasty, which you're probably familiar with. These kinds of things can be used to handle residual pain after the fact. What has been quite important has been to consider, well, what drugs can be used for the treatment of pain. And I would mention and emphasize there is a very, very nice article that was published in the Mayo Clinic Proceedings here in October of this year. And it summarizes the drugs that can be used and the way in which they can be used to handle pain in patients with myeloma. Obviously, at the top of the list, we do have morphine and morphine derivatives, things like oxycodone and the like. We want to avoid those if possible. We do have opioids, which are quite helpful. I would emphasize that the tramadol or the tapinarodol, these two drugs are very helpful, especially for acute pain. For example, for an acute episode of pain, tramadol can be given as an IV shot and can dramatically reduce the pain, which makes ongoing pain control so much easier. For ongoing pain, Cymbalta, which is actually an antidepressant type drug, has ASCO level A evidence as useful for neuropathy-related pain, and so that would be the #1 drug of choice to consider for example, Velcade neuropathy. Using anti-inflammatory treatment can be helpful, including steroids or the non-steroidal things like Aleve or Advil, which of course have to be used with caution because of kidney issues in myeloma patients. There can be topical agents, which I've listed there. If you go to the next slide, slide 31, you can see that in addition, vitamin supplements can be used, and we do have a list of those at our website, or you can call our hotline to discuss the different supplement vitamin cocktails that can be used. I would just say that the results with those are a little bit sporadic and certainly cannot be guaranteed. There are some other approaches which I've listed there. I would draw attention to one which I list there, which you'll see, acupressure. And this is kind of an interesting new approach, and this is a special type of a pressure device that is applied to the ear. And then there are corresponding meridian parts of the body that correspond to the acupressure on the ear, and it can relieve pain in different parts of the body. And this is a new approach that has been developed by a team in Florida and can be considered for ongoing troublesome pain. And so these are a few ideas to think about for the management of pain for patients with myeloma. And so my final bottom lines, lots of new information from ASH, as I list on slide number 32. Lots of new information that I'm sure, and this is a special year, I believe, for ASH, where there is information that can be applied very soon to the day-to-day care of myeloma patients. And then just to emphasize that it is usually possible to manage myeloma pain, and so I would encourage all patients with pain, acute or ongoing, to talk to their hematologist oncologist, get a referral to a pain specialist if necessary. This can sometimes be extraordinarily helpful to get a nerve block or to get special recommendations or care. And so with that, I will draw my presentation to a close. I really hope that this has been useful and instructive, and I'm happy now we have some time available for questions. So thank you.
Your first question comes from the line of Thomas Donnan.
Yes, we seem to be having difficulty with the slides. They almost all come through blurry. They're not, some of them have everything, but...
Oh.
Thomas, this is Susie Novus. I don't know why that is happening, but...
Sorry about that.
I'm going to give you, anybody who wants to get the slides, our toll-free number is 800-452-2873, and we'll make sure that the slides get to you.
Okay.
Thank you.
So we're getting feedback that most people seem to be having no trouble with the slides, but we'll absolutely get a clean set to you, okay? Sorry about that.
Thank you.
Okay. Any further questions?
Yes, sir. We have another question. We have a question from Bill Brewster.
Dr. Durie, fantastic work going on multiple myeloma. I have a question. I have high-risk myeloma, and I am currently at about 0.13 on my M-spike.
Okay.
I'm a little confused on the MRD testing. I don't think that would apply to me. I'm not close to
Right.
needing
that. A very good point. So the MRD test is applied when all of the other testing is negative, so that when you have a complete remission, or with our old parlance, a stringent complete remission. And so if you have a measurable spike, which you have, obviously the MRD test would be most likely positive. So it doesn't completely apply in your case, although in our trials, this would be an example of where we would want to do a trial to see if it was appropriate to achieve MRD negative, for a higher risk genetic case, to maybe use a Velcade combination or something, or some newer combination, to see if we could achieve a CR and then an MRD negative. So, but not to do the test right now.
Right. I am. I guess I need to talk with my oncologist about what testing I should have done with all these new treatments, with CD38 and proteasome inhibitors and so forth.
Right.
To get the right, when I relapse, currently I'm on the Velcade cytox treatment.
Okay.
When I relapse, I guess I should be asking what testing I should have to get the best drug combination for the next phase.
I think that this would be a good thing to chat with your doctor about. A couple of other points. One is that you could always call one of our hotline staff, and they could perhaps discuss what treatment you've had, and then what would be maybe some good follow-on options. The other thing is that as part of our Black Swan project, we are trying to analyze this. If there is obvious residual disease, what are the recommended options in this case? And so we have some studies going on with that. So in the next year or so, we might have some better, solid things to say about that.
Well, thank you very much, and keep up the good work. We have a lot of room for great optimism.
Thank you so much.
Thank you. Good night.
Good night.
Your next question comes from the line of Sarari Sharoff.
Yeah, Dr. Durie, thanks a lot for a lot of really exciting new information. My question, actually there are two, is regarding the minimal residual testing. If this is regarding my wife, if a patient is in complete remission and there's a development of oligoclonal band, I guess that is a new M protein which is unrelated to the baseline heavy or light chain. Is the MRD, the different methods, and in particular the 8-color flow, specific enough to properly distinguish? I understand that it's supposed to be benign, right? The new,
Sure.
Does it distinguish?
Okay. So 2 or 3 points about this. Is this occurring within a few months after a stem cell transplant, perhaps?
Yes, that is correct.
Yes. So this is something that does occur not uncommonly in this setting, and it reflects some recovery of the normal immune system, which often is associated with some of these oligoclonal or small spike bands, which come and then they tend to disappear in the coming months. They obviously are not the same type of protein as the original myeloma protein, and as you are saying, they are benign. They are, in addition, usually a very good sign prognostically. They tend to correlate with a relatively longer remission. The Spanish team have looked at this closely. So this is a good sign. with the new flow method, we might be able to document that the cells associated with this have this MGUS signature, and so this is just something to follow up with. But I think from a practical standpoint, I would track this, and most likely it will go away in the coming weeks or 2-3 months. So a good sign that will hopefully disappear.
Yeah, so I did look up the research on that, but specifically whether the 8-color flow is able to, distinguish that and not falsely classify it as a positive. Is that already known?
Yeah, this is known. Yeah, so we have 3 categories on the MRD flow test. We have negative, and then we have positive, which with what I showed as an MGUS signature, which would be the case here, or we have positive with a myeloma signature, where we have the pattern of the myeloma. Yeah, so there are the 3 results that come out of that testing, yes.
Okay, thanks. So I take it that we should be able to take another sort of question, somewhat related. On slide 5, I guess you did point out that there are cases where the next generation sequencing was negative and the flow is positive, which I guess would be very good to infer that the flow is more sensitive. However, how do we know that the positive actually is not erroneous and that it might just not be specific enough? I mean, this is just a devil's advocate kind of a question.
Yeah. No, it's okay. No. These are very, very important questions that we are quite focused on. So these cells have the pattern of the original myeloma. There's a special combination of these 8 colors, which is characteristic of the myeloma. And so for it to be called positive, it has to have some variation on that original pattern, so that we can say that it is myeloma. And it's compared against a computer database which now has around about 3,000 cases for comparison, so that we can say, oh yes, it is a myeloma and not something else. Okay, but it's a very important aspect for security, yes.
Okay, thank you very much, Doctor.
No problem.
Your next question comes from the line of Ann Baldrick.
Hello. I'm new to multiple myeloma. I was just diagnosed October 26th by Dr. Lawback in Boston.
Okay.
And I have just finished my first round. I live in Kentucky, and I have a doctor here, but I'm going up there for the program.
Okay.
I am IgA. This just happened to me, so needless to say, I'm sure
it's very overwhelming with all this kind of new information. I'm so sorry about that.
Well, no, I loved your talk. I loved it. Actually, I'm a statistician by trade, so I really enjoyed this a lot. So, but I guess I really have 2 questions that bother me a lot.
Okay.
The first one is, when I was diagnosed, I was misdiagnosed back in June. But when I was re-diagnosed back in September, I did not have any of that CRAB that showed up, but I had
Right. So you really didn't have any symptoms.
Right. I didn't have any symptoms, but Dana-Farber found me at 70% on the bone marrow, whereas in Kentucky they found me 50%. So
a little bit of variation there, yeah.
That's too much of a variation for me, but anyway. Making a long story short, I keep seeing all of this stuff about the CRAB. Does that mean going forward I am going to have symptoms of those 4?
Okay, good question. So quite possibly not. It sounds like you've been diagnosed at a pretty early stage, and you would fit into what we call these new diagnostic criteria, where we're picking up patients with smoldering myeloma, basically, who are in this early myeloma category. And so when we start treatment in someone like you, you are going to get your myeloma under control and actually may never have these CRAB criteria show up, which is wonderful. And we do see a lot more of that now, where myeloma patients are fortunately diagnosed early and get fantastic early treatment and, get long remissions and just don't ever get the CRAB criteria. So hopefully that can be the case for you.
Well, the way mine was diagnosed is I was sleeping like 16 hours a day. I was just tired all the time. But my second question is, I keep getting over and over this median, and I know you all use the median for your average, which makes sense because you've got the outliers there. But my concern is I don't read anything like, am I doomed to die in 5 years?
Okay, so I apologize, and so to show these kind of statistics fast, and so actually with the constant introduction of all these new drugs, the goalposts are shifting all the time, and so that study that I showed, for example, was started in 2008, and so those are the outcomes based on treatments available going back to 2008. So even now, that's old data, and so the outcome would be better. And there are subsets of patients that would be living way beyond that with the introduction of the new drugs. And so the advantage of this trial is that we do have the long follow-up, which does show the difference between the 3 drugs and the 2 drugs, but it doesn't really show real-world outcomes today here in 2015. Are you with me? And so
yes, I am.
It's a very important point to draw attention to this, that the outcomes we would expect today with BRD, with follow-on treatment, would be significantly better, actually. Okay?
So you can have like maybe 10, 15 years? I mean, it's not...
Absolutely.
Good.
Absolutely.
Okay, and I did want to tell you that I am on the 3... the Velcade, Revlimid, and dexamethasone.
Excellent.
And this is my off week, so that's why I'm saying today. The 2 weeks on.
Good. Yeah, it's not the easiest regimen. So thank you so much. We're going to have to move on, but very important points.
Thank you.
Your next question comes from the line of John Bianco.
Thank you, Dr. Durie, for the presentation and for your last questionnaire. I have survived for 15 years, so there's a lot of hope.
Wonderful. Thank you.
Dr. Durie, I'm just coming off of VPD, Velcade, pomalidomide, Dex. It was effective for about a year and a half, and now my numbers are starting to go back up.
Okay.
I'm planning on starting Carfilzomib next week, Monday and Tuesday.
Okay.
So they're recommending a 20/20 dose to start off. Does that make sense?
I think it's very good to start low with Carfilzomib. We always start low, yes, and then escalate with care. Actually, some patients have excellent response without dose escalation. However, there's an important subset where the dose escalation up to like 56 milligrams is necessary to get the best response. But it's always good to start low, okay? Both in terms of looking for that efficacy as well as possible side effects.
And what about the once-a-week scenario? Because I am working, and to go in twice a week is really a challenge.
Well, I would just draw the once-a-week data to the attention of your doctor for discussion. So you'll see I've listed the abstract numbers there, so I would just mention it to your doctor. I think this is something you guys would need to decide, but I think that my reading of the data is the results are equivalent. So that's why I emphasize that it's very, very important and helpful for someone like you.
Okay, so start low and go there then.
Yes. But talk to your doctor about it, but I think it's the way to go.
Okay. And I'd like to just mention PetCT, invaluable, because without that, I would have continued with the therapy that was not working for another 6 weeks and doing more blood work and then going from there. And with the PetCT, we could see what was going on with some lesions, and we knew it was time to move on. So I just want to mention that.
Everyone. Good, thank you for that. And I didn't touch on it, but it's one of my pearls. The PetCT monitoring under Abstract 395 highlights that point. So thank you for that.
Thank you very much.
Okay, I think that I'm getting signals that maybe we can't take any more calls right now, but I suspect there might be quite a few more questions, and so I would encourage you guys to call into the hotline or email us and let us know if any issues that you want to follow up on, okay? And I'll turn it back over to Susie.
Well, thank you, Brian. That was really wonderful, and I'm sure everyone on tonight's call really appreciated your updates. And like you were saying, a lot of listeners will still have some follow-up questions. So as you were mentioning, you can call our info line. They're here to help. The toll-free number is 800-452-2873. They're available Monday through Thursday, 9 a.m. to 4 p.m. Pacific Standard Time. So another way to really stay abreast of all the new data and how it impacts your treatment options is to attend one of our patient seminars. I wanted to let you know that our first seminar in the new year will be held in Boca Raton, Florida, February 26th and 27th. So if you want to register early, just call the IMF, and again, our number is 800-452-2873, and I'm sure you'll be glad you did, and attending Boca seminar is always really wonderful. I also want to let you know that, as always, the IMF will be attending the annual meeting of ASH, and some of our member patients will be there with us. They'll be tweeting, blogging, and sharing their experience. So if you can't be at ASH, you should check in to see what they're talking about, and you'll feel like you're right there. You can find out on our website how to access those blogs and tweets. Again, I want to thank our sponsors. Without them, we wouldn't be able to do these calls, so thank you so much to Bristol Myers Squibb, Celgene, and Takeda Oncology. And before we close, I want to thank our wonderful support group team here at the IMF. Robin, Kelly, Nancy, Sue, and Ann, they're the ones who are out there working with all the support groups across the country and helping them in so many positive ways. And if there isn't a support group near you, why don't you call the IMF and get with one of the team, and they'll help you start one. So that's it. I want to wish everyone a very happy Thanksgiving, and
we need to do the closing.
I hope to see you soon, and you can't go away yet because Dr. Durie is reminding me we need to do the polling. Okay.
Right.
Don't anybody hang up.
Right. So if you would, Victoria, if you would like to take people through the final polling questions, that would be great.
Do you have any closing remarks?
Victoria, again, I just want to wish everybody a very happy Thanksgiving, and don't forget we're always here to help. So thank you all very much, and thanks, Victoria, for your help tonight.
Thank you all.
Good night.
Good night.